Today, we are going to discuss a very important topic, and the topic which is going to be more relevant in the days to come because aging population is increasing in the world, and it is like a epidemic growing into proportions like an epidemic, and we will be facing with many old people with different conditions along with diabetes, and we have to treat them properly and optimally. Elderly people means anybody above 65 years is considered as elderly, and the diabetes treatment is not the same like any other person, young person. You have to be very careful. This needs not only the care and extra precaution, but also needs some compassion. Old people are like young babies, and we have, because of their difficulties in hearing and vision and all other things, their own difficulties, they will not be able to even express their complaints. And so we have to give all those consideration while taking history. It's always better to keep a attender along with the elderly man and discuss with all their priorities and what are their facility, what facilities he has, what is the social support he is having, what food preferences he has, what drugs he is allergic to, what are the other comorbidities he is having. All these things have to be discussed before we plan for our diabetic treatment. So this diabetes care in elderly, I have my roadmap for this diabetes in elderly is divided into these 7 topics, like the epidemic of the 20. It is like an epidemic of 21st century, and the health status of the elderly is heterogeneous. Means each elderly person is not the same as another elderly person. Two people are different, and our approach also should be different. Then the pathophysiology of aging, which is relevant to diabetes. What are the changes which occur in the body of an old man, which can affect the insulin secretion, the beta cells, the renal problems, and the liver problems? What are the things which change with age and which can affect our approach to the diabetes? Then the comorbid conditions. Usually not only the changes which occur with the age, but usually by the time the patient is 65 years and old, he is usually having more than means not only diabetes, he has other comorbidities also, usually hypertension or heart disease or any renal problem or any other neurological and other problems. Then we have to optimize the treatment. Means these varied people, same old man, 65-year-old man can be very healthy and walking, looking after himself very well. And same 65-year-old man can be bedridden. Some people can be dementic, means with partial dementia and other things. So not only the physical disability, the mental and neurological disabilities also have to be considered while treating the patient. And then we will go into the main treatment of management of elderly, which drugs are more useful and other things. And then I will summarize my talk with this all the points. So why we call this elderly diabetics as an epidemic means we are going to witness a very huge burden of elderly people in future. See, and it will be such a huge that it is not only cutting into the exchequer of our government bills. These health bills are maximum utilized. All the facilities, about 60% of the AMC beds are utilized by elderly people. So we will be doing a great human service by preventing these people from coming into the AMC. And so in that way, we'll be saving a lot of money, and we'll be able to utilize them for the other people in the health services who need health services. So why it is called the epidemic of 21st century? Because there is world population is aging, and 1/3 of US adults over the age of 65 years are diabetics, and approximately of these half of them are undiagnosed and 1/3 of them are pre-diabetics. Actually speaking, if you don't do screening in adults, elderly people, the elderly people may not be having much symptoms also. They don't have even thirst also like the younger people. And they may be having only lethargy, general weakness. Unless we test, we may be missing many times the blood sugar levels. So we have to be very vigilant whom to test. I'll be going through all those things later on. Now, the persons with diabetes are living longer nowadays, so we are having more patients. And the management of elderly diabetics has improved. The fertility has decreased, another point. Because all the people in all the families, there is 2 is the norm nowadays. Nobody has more than 2 children on the average. And so fertility is decreasing and longevity is increasing. That's why the aging in the population is increasing. The prevalence of type 2 diabetes continues to increase steadily because the people are living longer and people are growing heavier also. People who are obesity is also contributing to this number of diabetics, because not only they are living longer, they are becoming obese, and obesity increases the chances of diabetes. Next, out of the 11.2 crores of people, obese or elderly people in India, 3.7 crores suffer with dementia. 11.2 crores. This is 37 lakhs suffer from dementia, 4 crores suffer from poor vision, and 16 lakhs suffer from stroke. And 1 in 3 elderly people have arthritic problems, and 1 in 3 have hypertension, 1 in 5 have diabetes in 65 and old, and 1 in 4 suffer from depression. So depression is so common, we miss many times. They may be in small, the grades of depression may be different. They may be slightly depressed, and we may miss many times. But the prevalence is more. 1 in 10 have falls and sustain fractures. 1 in 3 have bowel disorders, and cancer is 10 times more in the elderly. So you can imagine the burden, the huge burden of health on these elderly people. So in India, almost 60.8% of type 2 diabetic patients are aged above 60 years. Means 2/3 of the patients, of diabetic patients which we see, are above 60 years. So we must have first-hand knowledge of how to treat these old people, what is the difference in treating old and the young. Type 1 diabetes treatment is completely different. Young healthy diabetic treating is different. Elderly people above 60, the approach will be slightly different. So another point next. One is, this is the epidemic, the burden is more. Now the people, old people, elderly people are different in their own way. Means all the elderly people are not the same. So they may be because of the social factors, they may be because of the psychological factors, maybe because of the physiological factors. Like in social factors, socioeconomic status, housing, residency, marital status, erroneous beliefs, food faddism, and all these things. By these things also, the elderly people are different. Means some people have some different belief, their food habits will be different, and another person may be he may be non-vegetarian, only eats non-veg. So different. The difference is like that by the sociological factors. Psychological factors is people who believe in cultural factors, cognitive functioning will be, some people may be dementic, some people may be very alert. We have seen people with 90-year-old very alert and speaking very nicely, having now in our doctors also we see very elderly doctors speaking so nicely. And some people at the age of 60, 65 itself become demented, and they go into Alzheimer's. Many people go into Alzheimer's also. So sense of control of and health related behaviors means if they are dementic, we have to estimate whether this person can be able to treat himself, take care of himself. Can he monitor his blood sugars? Can he take injection properly? All these things depend upon their mental status also. Then physiological factors like health, motor performance, senses, dental status, other chronic diseases, what are the drugs he is taking. In that way also, there are so many heterogeneity is there. People are different. Similarly, this slide also says the same thing. Same person, supposing a person of 60 years, he is a very fit person. He can take care of himself well. This person the third person can manage himself well. Fourth person may be slightly vulnerable. Fifth person is mildly frail. Sixth is moderately frail. Sixth is very frail. Seventh is very severely frail. And seventh is the terminally ill. All these elderly people can be divided into different types. This is the heterogeneity in the elderly people. Why they are heterogeneous? This is the first challenge, and we need to consider this in the treatment and therapeutic options. Like healthy working individuals, functionally and cognitively frail people, and patients in nursing homes, variable degrees of insulin deficiency, peripheral and hepatic insulin resistance. So these are the things which can be different in different people. They can be suffering with depression. So high prevalence is there in depression in type 2 diabetes. Not only the normal elderly people, 1 in 3 people in elderly diabetics are having some form of depression or the other. And this increases this disability increases, leading to hindrance in the self-care, increased risk of hyperglycemia, and increased risk of diabetic complications because they can't treat themselves properly. They avoid taking all the pills. Means whatever tablets are prescribed, they don't take properly, and all those things. And decreased quality of life will be there, and they need increased health care. And so similarly, this aging has so many things to be considered, like urinary incontinence and cardiovascular disease, cognitive decline, depression, polypharmacy. Another very important point. If the patient is, and many people, because they are prone for this injuries, fall, because the balance is different, and so many dementia, arthritis, posterior columns are weak, and there may be cerebrovascular problems and other things. So they are more prone to getting injuries, bone fractures, because the bones are weak, and as well as history of falls are also more. So for the type 2 diabetes for the elderly, the pathogenesis is not only the reduced insulin secretion, sarcopenia, increased adipose tissue, decreased physical activity. Because of the decreased mobility and sluggish metabolism, unhealthy eating, non-compliance of the medication, and inability to self-monitoring and management, this glycemic control is not good usually, and we have to take extra care in these people. So we can divide these heterogeneous elderly people into different categories. Like first is category 1 is functionally independent. The treatment approach will be slightly different. Category 2 is functionally dependent, patients in assisted care facilities. 2A is frail elderly. 2B is elderly with dementia. And category 3 is elderly with advanced illness and life expectancy less than 5 years. So in category 3 people, there is no point in controlling the sugars tightly and having a goal. Means okay, all these things are not required in this. We have to keep them comfortable, that's all. Only thing is we should see that they don't go into hypoglycemia, they don't have very, very high sugars. But we can relax in these things. Even in blood pressure management also, in these elderly people with life expectancy of 5 years, the main thing we should do is to keep them comfortable. Now, comorbidities in the elderly and polypharmacy. This is very important. Average number of medications and the number of comorbidities, if they are compared. If the patient has no comorbidity, usually elderly person takes about 6 medication. One comorbidity, this was study was maybe 5 only here. With 2 comorbidities, it was 8 medications. With 3 comorbidities, it was 9.6 on the average medications. 4 comorbidities, it was 11.75, like that. With increase in the comorbidity, the number of medications increase. It seems in America, the average number of pills a patient takes, elderly patient takes is 12, it seems. So here, when patient has 7 comorbidities, he can consume up to 17 pills. So polypharmacy is another major problem. Interaction of the medications and forgetting some adherence to the medication will be difficult. If the number of drugs are more, the adherence will be less. Diabetes management in older adults presents challenge because there is extensive variability in terms of clinical presentation, psychosocial environment, and resource availability. Even this is important because in elderly persons in our villages who are very poor, if you go, and they have all the comorbidities also, it becomes very difficult for them to take all the medications. Whichever is, they will take only whichever is very, very essential, like diabetic medication or blood pressure medicine. They will not take other medications because of the monetary constraints. The older diabetic adults may either have elderly onset disease or long-standing diabetes with onset in the middle. This is another heterogeneity. See, if there is a family history of diabetes, a patient can become diabetic around 45, 50. If the parents are diabetic and all, or one parent is diabetic, he is likely to become. Or without any family history also, person, if he lives up to 65 years, he is likely to get diabetes. So there are different types of people who are getting diabetes are in the middle age and becoming old, or people who are normal up to 65 years and then becoming diabetic. So their approach will be different. The complications will be different. So this is another type of heterogeneity in elderly people. Hence, diabetes care in elderly needs comprehensive overview, treatment not only for hyperglycemia and risk factors, but also comorbid diseases. And the functional limitation should be taken into consideration when setting treatment targets. So if all these things will be, again, many of the points will be repeated, because I want to drive in a point that we have to be more careful while treating the old people. We cannot, and each and every drug, how it is acting, whether it is required or not, we have to think twice before we prescribe the medication. So we have to assess them comprehensively. Now, what is his age? What are the comorbidities? What are the social, psychological, psychosocial disorders like depression? Whether he is isolated, alone, staying alone in the house, whether there is any social support or not. Specific geriatric conditions like dementia, falls, functional disability. Whether previous or predicted high healthcare utilization, was he admitted previously? Any person who gets repeatedly admitted is very prone for health problems, and so we have to be more careful in that. We have to improve his general condition also along with, and ability to perform functional tasks whether he is able to take insulin injection or not. We just prescribe injection. Who are going to give the injection to him? Whether he has got that facility, whether he will be able to take it or not. I'll tell. Then is there any fall history? Urinary and fecal incontinence, is it there? Does he have pain also? Just not treating a diabetes also, because he's having, the elderly people have suffer with many other things. So pain also, history, we have to take the history of pain also. Then social support, which I told you, family, friends, whether they are there or not. Whether he has depression. If he has depression, he will not be enthusiastic to continue the treatment. He will not follow our instructions properly. Then vision and hearing difficulties. Then whether the patient has any specified durable power of attorney. This is another thing. In foreign countries, it is there more, because he has to have a attorney to for any specified, he can prefer what treatment he needs and all those things. Next, what is the pathophysiology in the aging which is relevant to diabetes? So age has an important impact in the body composition. It is vice versa also. Diabetes has an important impact on the body composition, and age also has an important contribution to diabetes. I'll tell you how. See, lean body mass, decreases of lean body mass and total body water. Total body water and lean body mass is decreased. Increase in the body fat. Muscle comes down, fat increases. Reduction in the basal metabolic rate. Requirements of most micronutrients are not reduced. Another point is, even the diet is reduced, but the micronutrient requirement is the same. Impaired absorption of some vitamins and minerals like cobalamin and calcium. So we may have to subsidize, means we have to substitute these things. We have to give them because the absorption is less. The reduced ability to synthesize vitamin D and exposure to sunlight is lower. So vitamin D also has to be given. Similarly, vitamin C, beta carotene, vitamin A, zinc, these deficiencies will be there in elderly, and they have to be checked, and we have to replenish them properly. Age-related physiological changes, whether associated with disease or not, have influence on nutrient requirements and food preferences in the elderly. I'll tell you in further slides. So the general metabolic and hormonal changes occur with age, like which are relevant to diabetes. Like insulin secretion is decreased. What is known as the pulsatile secretion phase decreases. First phase of secretion of insulin is decreased in elderly people. Insulin resistance is increased because of the higher fats to muscle ratio, lack of physical activity, disproportionate loss of skeletal muscle. So metabolic syndrome is also common in elderly because of this fat redistribution. Hepatic glucose metabolism, increased fasting hepatic glucose output is increased, and there is altered incretin response. There is decreased regenerative capacity of beta cells. Beta cells regenerating capacity is decreased, so insulin requirement slowly increases with age. Reduced mitochondrial oxidative capacity. These are the general metabolic and hormonal changes with age, which are relevant to diabetes. Genetic factors like pro-inflammatory cytokines, mitochondrial alterations with age lead to increased insulin resistance. Renal threshold is increased, so glycosuria goes undetected. Hormonal changes like growth hormone, androgens, testosterone decrease with aging and lead to decreased lean body mass and increased adiposity. New research has shown that aging and obesity represent low-grade inflammatory state. This is very important. When we study about frailty, we will be knowing more. With age, it's like increasing age is like a low-grade inflammatory state. Then there is endothelial dysfunction. Insulin-mediated vasodilatation causes endothelial dysfunction and subsequent increased atherosclerosis. This is the reason for atherosclerosis in the elderly, one of the reasons. Aging decreases the capacity of cells remarkably and causes increased insulin resistance, deficient insulin secretion because of the beta cell dysfunction. Then suboptimal insulin levels in response to hyperglycemia. Yeah, when the sugars are more, insulin response is less. Reduced beta cell sensitivity to glucose-dependent insulin-tropic peptide. There is high prevalence of metabolic syndrome, weight gain, sarcopenia, redistribution of fat. This leads to visceral adiposity and thereby insulin resistance. Old age, many people in America and other places, elderly people with obesity, this is double whammy. If they both are obese also and elderly, then problems are more for them. Next, we'll touch about something about the comorbid conditions and the geriatric syndromes. In addition to the microvascular and macrovascular diseases, geriatric syndromes occur at higher frequency in older diabetics and may affect the health outcomes and quality of life. One is cognitive dysfunction. Diabetes is associated with 1.5-fold increased risk of cognitive impairment and 1.6-fold increased risk of dementia. Normally, elderly will have this, and if they are diabetic, they have still further increase. Depression is the prevalence of depression in diabetics is twice that of an age-matched general population. Depression is twice. And the treatment of serotonin reuptake inhibitor improves quality of life and consequently diabetes control. So, in a diabetic depressive patient, if it proved case, usually we give mirtazapine, which is good, which increases the quality of life for him, and better he takes care of the diabetes also properly and other things. Another point is the polypharmacy, which we discussed earlier. So polypharmacy can increase and hamper increase the adverse events. Severe hypoglycemia can be there because of the interaction of the drug sometimes, drug and drug interactions, and interactions with coexisting morbidities. Cost is increased, non-adherence will be more because of this. So many medicines they will not be able to take, and decreased quality of life if patient is on many drugs. Then cognitive impairment also. Common observation is seen in this in diabetes. Threefold increase in with risk of hypoglycemia will be there. Because if patient is already having cognitive impairment, he will be missing drugs, he will be forgetting taking drugs, or he may take twice same drug. So the hypoglycemic episodes will be more in such people. Increased risk of cardiovascular events and death. And it is monitoring glucose, adjusting insulin dosages, monitoring timing and content of the diet. All these things cannot be done because of the cognitive impairment. Now, other comorbid conditions like physical disability, Dupuytren's contracture, stenosing tenosynovitis, carpal tunnel syndrome, adhesive capsulitis, diffuse idiopathic skeletal hyperostosis, osteoporosis, osteoarthritis, neuropathic osteo or Charcot joints are all associated with long-standing poor glycemic control. Very important. Next, elderly people with diabetes are at increased risk of falls and autonomic neuropathy. There is a role of targeted exercise program and comprehensive geriatric assessment in intervention falls. Yeah, if the patient diabetic elderly comes with history of falls, the exercise program should be more. See, another important point is usually we ask them to walk, we ask them to do some exercises, but most important is strengthening the legs. They should, the hamstring muscles and the quadriceps get weakened so much that the balance also is hampered, and posterior columns are involved, joints sense is decreased, and then there is also ischemia to the brain, blood pressure because of the high blood pressure, because of the circulatory problem. So many things add up for these falls. So one important thing we can do for them is, if they are able to do some exercise, they should be asked to do squatting exercises, sit and stand for 10 times at a time for 3 or 4 times where 2 revisions should be done. And that's a very good exercise. Not only the hand, the dumbbell, 2-3 kg dumbbell weightlifting and other things are good for the hands, but more than that, legs are very important. Leg strengthening muscle exercises is very important in elderly diabetics. Urinary incontinence is a very, very important complication, very frequent complication, and the risk factors for incontinence include poor diabetic control and urinary tract infections, vaginal infections, autonomic neuropathy. All these things have to be tackled. So physical disability, twofold increased risk of disabilities will be there in diabetics, and the risk of falls and fractures will be there. And so many things are involved in the pathogenesis of hyperglycemia in elderly person. And along with that, they have coexisting illnesses, they have insulin, same thing I'm repeating, medications, so many medications will be there. And then genetics also plays an important part. Not only that, in person, most important thing we have to take care while treating a diabetic is avoidance of hypoglycemia. But we must also know that the risk factors for hypoglycemia in elderly people. What are the risk factors? If an elderly person is an alcoholic, he will come repeatedly with hypoglycemia. So this should be tackled properly. Alcohol, if he is able to stop, that's the best thing. Then autonomic neuropathy and adrenergic blocking agents. The adrenergic blocking agents should be avoided. Then cognitive impairment, if it is there, it should be tackled properly. We should not give them complex treatment regimens. So, and then if the patient has hepatic dysfunction, polypharmacy should be avoided. Poor nutrition, always usually hypoglycemic episode, doesn't take food and takes the medication and he comes with hypoglycemia. So nutrition, his food habits, timings of the food, the quantity of the food should be properly managed. And if he has recent hospitalization, then he is likely to come with hypoglycemia. Renal insufficiency, the most important point is this. If the patient is going into renal insufficiency, early diabetic nephropathy means the episodes of hypoglycemia will be more. Then we should avoid sedative agents in these patients. This will also increase, means we'll be mimicking the hypoglycemia, and we should avoid these things. Therapy with sulfonylureas, yes, this is now a controversy. We are not treating elderly people with sulfonylureas. Only the later generation modern sulfonylureas we are using with caution. And insulin also can cause repeated episodes of hypoglycemia. Tight glycemic control is also not required. When we overzealously treat, then they go into hypoglycemic episodes. Risk of hypoglycemia is greater in older patients, and when they are having more comorbid events, hypoglycemia is seen more, and increased mortality is because of the hypoglycemia. They go into cardiac complications and other things. Increased risk of fall can be there because of hypoglycemia. Increased risk of cardiovascular events. Increased complications because of hypoglycemia also. There is a greater barrier for optimal. So because of hypoglycemia, we sometimes don't treat the blood sugars optimally. But diabetic therapies with lowest rates of hypoglycemia should be considered. For very elderly people, hypoglycemia should be avoided. Next, these are the conditions in which we should not completely depend on HbA1c only, because in age, because of the increased insulin resistance, the HbA1c can be slightly high. In African American people, it is high. In iron deficiency, wherever there is decreased RBC turnover, longer glycation exposure will be there, and so HbA1c will be high. And hemolytic anemia, sickle cell anemia, thalassemia, increased RBC turnover, HbA1c will be less. Anemia of chronic diseases, any anemia of chronic diseases, this can be if the RBC production is more, then the HbA1c will be less. If the RBC production is less, then the HbA1c will be more. So if you have given recent transfusion, increased RBC turnover is there, HbA1c will be less. Similarly, in polycythemia, longer RBC lifespan will be there, HbA1c will be more. In hemoglobinopathies, interference with hemoglobin variants, so HbA1c will be less. So similarly, we should not completely depend on HbA1c. And suppose the patient is on erythropoietin treatment, increased young RBCs and shorter RBC lifespan, HbA1c will be less. Metabolic acidosis and uremia, the carbamylation of hemoglobin will be there, and so their HbA1c will be more. So now we'll come to another main point, is how to optimize the diabetes care. All these things should be considered: heterogeneity, comorbid conditions, physiological changes, life expectancy. So if life expectancy is only 5 years or less than 5 years, then there is no point in optimizing the blood sugar levels. Functional status, if he is able to see a 65-year-old man, a 70-year-old man can be sturdy and very fit person also, and he can be treated like any other young person. But same person, if he is bedridden, then there is no point in treating him very aggressively. No randomized control trials are there in these elderly people because of the heterogeneity. They are not included in any randomized control trials. Safety of the drugs is very important, and to polypharmacy we should try to avoid number of pills. Next, the goal should be, number one, microvascular and macrovascular complications should be reduced and prevented, and prevent the treatment-related complications like hypoglycemia. Individualize. These are the words which are very important. I'll come back in the summary again. And target HbA1c level should be individualized per patient. Keep the patient asymptomatic. Preserve the quality of life and dignity, most important in elderly people. Patients and relatives should be educated about hypoglycemia. There's one more point important. Physical activity should be addressed depending on the functional status. Supposing a patient is visually impaired and you cannot ask him to go for a walk and other things without any accompanying person and all. And if they are having neurological problems, osteoarthritis, his physical activity should be adjusted accordingly. And care should be taken to prevent hypoglycemia because of increased risk of fall, arrhythmias, and cerebrovascular accident. Polypharmacy should be same thing is repeated again. So we have to individualize the HbA1c levels. Older people who are functional, cognitively intact, have significant life expectancy should receive diabetes care using goals developed for the younger adults. Glycemic goals of older adults not meeting the above criteria may be relaxed using individualized criteria, but hyperglycemia leading to symptoms of risk of acute hyperglycemic complication should be avoided. Not that you relax and the patient goes into hyperglycemia and comes someday suddenly with ketoacidosis and all. So we have to be careful, but we should not, if you relax also, they should be under the sugar should be under margin. And the screening of the diabetic complication should be individualized in older adults, but particular attention should be paid to complications that would lead to functional impairment. The patients who is free of major concurrent illness and who has life expectancy of at least 10 to 15 years should have A1C target of 7. If it can be achieved without any risk, we should keep the target at 7. Patient with comorbid conditions who requires combination medication regimen, including insulin, should have A1C target of 8. And the patient with advanced microvascular complications, major comorbidities, life expectancy less than 5 years, unlikely to benefit with aggressive glucose lowering management, should have A1C target of between 8 and 9. So the recommendations for management of diabetes is Glycemic control, as I said, 7 for healthy people, 8 for with comorbidities. Hypertension, 140/80 normal, with renal problems, 130/80. Lipids, LDL 100, HDL more than 40, triglycerides less than 150. Aspirin, 75 to 325 can be given if there is no contraindication. Smoking cessation and the geriatric syndrome should be screened properly. And then we'll come to the management. In this, we have preventive strategies, lifestyle. See, who are the persons whom we should screen actually? You see, this is a teamwork involving the physician, educator, neurologist, foot care specialist, ophthalmologist, cardiologist, nephrologist, and a psychiatrist. Diabetes self-care, self-management education is very important and may need to account for possible impairments in sensation, vision, hearing, and these things should be cognition, other things should be taken into consideration while teaching them. Nutrition is very important, hydration is important, physical activity is important, stress management and cognitive function management is important. Prevention of ulcers and falls, diabetic ulcer, very common with long-standing diabetes because of the diabetic neuropathy, because of infection, because of injuries. We don't even believe that sometimes a person walks on the nail completely punctures the leg and he doesn't know at all, and that injury increases and gets infected. So sensation is completely gone. We should be very careful. And therapy administration and monitoring and end of life care, all these things are involved in this diabetes care. So this is one simple clock drawing test we call. Ask the patient to draw a clock and give the timing, say 10 past 11, not in a position to take injections also. Then, what are the preventive strategies? Whom to screen? We cannot go on screening all the elderly people. So at least people who are overweight, people above the age of 40, family history of diabetes, then people with hypertension, definitely we should screen for diabetes. People with any other comorbidity, better to check for the diabetes also. Patients with sedentary physical activity, gestational diabetes anyway, we treat. Any history of macrosomia also we screen. Cardiovascular disease, anybody having cardiovascular, we have to screen. Then history of polycystic ovarian disease and acanthosis nigricans also, we screen for diabetes. People aged more than 30 years with a family history of diabetes. If there is family history of diabetes, more than 30 years, we have to screen once at least. And adults above 45 years, once at least we have to screen. And those who are obese, even less than 45, we have to screen without any family history. Then lifestyle modification. Lifestyle modification involves altering long-term habits typically and physical activity and maintaining a new behavior. We have to modify his behavior and maintain it properly. The lifestyle modification is based on the premise that if the factors which increase or decrease the stress on the client's life may be identified, it may be possible to alter the same as some aspect of client's lifestyle to decrease their overall stress. Lifestyle modification involves modification of behavioral, environmental, and psychological aspects. Thing is, it is very important in elderly people. It seems that lifestyle modification, the effects of lifestyle modification are better in elderly than in the younger people. If they properly modify, the effects are seen very early in elderly people. Nowadays, that is what is known as functional medicine. People are now able to reverse diabetes by reducing the weight, and so many things are coming now. They are treating the cause of the disease, not the symptom of the disease. So this lifestyle modification involves weight control, regular physical exercise for at least 30 to 45 minutes, 5 days a week, salt restriction for controlling the blood pressure, protein rich in complex carbohydrates, more fruits and vegetables, and less fats and sugars. Abstain from smoking and alcohol consumption. maintain positive attitude, manage stress. This is also, yoga is also very important. Meditation is also now coming in for the treatment of diabetes. And regular health checkup is very important. Regular health checkup, we should, there should be some way to prompt these patients to come for regular checkup, and their time is there every 3 years or 5 years, whatever. They have to check properly. Maybe this is this thing should come through ordinary means. We should make this compulsory. Showing the certificate of master health checkup only, they will be given further. Their job will continue. Like that, some government rule also should come so that that is inculcated in the patient. They come for regular checkups. Now, exercise. Same thing. Exercise is encouraged to decrease the. We have to decrease sedentary time. We have to ask the history, how much time he's seeing the TV, how much time he's on the cell phone, and all these things, and try to reduce them. They should be able to do 30 to 60 minutes of moderate intensity aerobic activity in most days of the week. At least 150 minutes of moderate intensity aerobic exercise per week, spread over at least 3 days per week, with no more than 2 consecutive days without exercise. Means if patient if he doesn't go for a walk for 2 days, third day he must go. Maximum 2 days holiday can be given while the patient is on walking. In the absence of contraindications, moderate to severe like moderate to severe proliferative retinopathy or severe coronary artery disease. If patient is having these things, any eye problem or heart problem, then they should not be given all this resistance training. Otherwise, if they are not there, then resistance training is also important. Only walking is not sufficient. So they should be given exercise with free weights, and at least twice a week they should do this resistance training also. Very important. Otherwise, patients go into sarcopenia. To avoid sarcopenia, resistance training is very important. Same thing, swimming, cycling, brisk walking, dancing, these are very important. Next, nutrition therapy. Nutrition, very important nowadays, more equally important than medication. Medication is going into the backseat nowadays. More than that is this nutrition and lifestyle modification. These are getting more importance nowadays. Nutrition is an integral part of diabetes care for all ages, but there are additional considerations for older adults and diabetics. Though energy needs decline with age, micronutrient needs are similar throughout the adulthood, and meeting micronutrient needs with lower calorie intake is challenging. Interventions may include encouraging smaller, more frequent meals, fortifying the usual foods, changing the food texture. Because of the dental problems, they have to change, and adding liquid nutrition supplements, either regular or diabetic specified formulas between the meals. It is very good idea to give 1 or 2 times protein shakes in between the meals. Either you give whey protein shake or even the Ensure or any other protein powder shake. This should be supplemented in all the diets for the elderly. Strategies that combine physical activity with nutrition therapy to promote weight loss may result in improved physical performance and function and reduce cardiometabolic risk in older patients. If the patients are, same thing I said, the leg muscles, the hamstring and quadriceps, they should be strengthened so that they walk briskly, they have good balance. This will, in a way, in turn, reduce their cardiometabolic risk also. So diet, there are different types of diets. So in an obese diabetic, weight loss can prevent progression of pre-diabetics to diabetes and decrease the risk of cardiovascular disease and result in partial remission in people with diabetes. A single dietary pattern may not be is best, or no single diabetic pattern is best. So different types of diets are there, But healthy dietary patterns such as Mediterranean diet, low carbohydrate diet, or the DASH diet are often recommended. Although evidence does not support one over the other. Anything is good. So according to ADA, reducing overall carbohydrate intake for individuals with diabetes has demonstrated most evidence for improving glycemia. For overweight people with type 2 diabetes, any diet that achieves weight loss is effective. So we have to, as per the preference of the patient, we can prescribe the diet, but most important is they should weigh whatever they are eating. If they just go on, I took only chapati and rice, or no, how much are you taking chapati? 2 chapati, not more than that we are not allowing you. 40 grams of rice, weigh that and take it. 1 bowl, small bowl of rice only. Take more of vegetables if you want, but rice you cannot eat more. So such restriction should be there. But patients can adjust their diet, whichever they like, preference according to their preference. They need not stop everything. Keto diet and other things have their own side effects, and they cannot continue their diet for long. So it is always better to reduce the calorie deficient diet. That is most important. If he spends about 2,500 kilocalories, give him 2,200 kilocalories every day, but he should be strict. Then slowly he will lose weight. We don't want him to lose weight more than 3 kgs in a month. That is also not good for his health. Mediterranean diet is recommended especially in older adults who have had coronary artery disease, as this diet is rich in fruit and vegetables. The principal aspects of this diet include proportionately high consumption of olive oil, legumes, unrefined cereals, fruits, vegetables, moderate high consumption of fish, and moderate consumption of dairy products like cheese and yogurt. Supplementation with omega-3 fatty acids such as salmon and cold water fish is also there. Consumption of cruciferous vegetables. This is important for us. Broccoli, cabbage, and cauliflower are associated with stroke prevention. It seems these contain certain ingredients which affect the vascular diseases. So consumption of cruciferous vegetables are associated with stroke prevention and may be beneficial if integrated in the diet of all elderly patients with vascular disease or vascular risk factors. So if a person has a TIA history, then he should eat more cabbage and cauliflower. So healthy diet should contain more vegetables, fruits, whole grains, healthy proteins, water. This is also important. Ask him to have an alarm of 2 hours or 3 hours in his cell phone. Every 3 hours he should take a glass of water. This is a very good advice. Next, pharmacotherapy. This I'll touch into it. So because these topics we go on repeatedly listen to, I am not going to go into details. Only thing is relevant to this diabetic elderly. Older patients are at the risk of adverse drug events due to age-related changes in pharmacokinetics, which is in particular reduced renal elimination. If the drug is given and it is not eliminated, it adds more and they go into hypoglycemia. And pharmacodynamics, increased sensitivity to certain medications. So these two things should also be considered. Usually, patient going into early diabetic nephropathy or albuminuria starts, then we should be slightly careful while giving the medication. These changes may translate into increased risk of hypoglycemia and potential need to reduce the doses of certain medications and attention to renal function to minimize the side effects. Type 2 diabetics with onset later in life is characterized with prominent defects in beta cell function, hepatic glucose overproduction, and insulin resistance. Vulnerability to hypoglycemia. Age appears to affect the counter-regulatory responses to hypoglycemia. Risks of under-treatment of hyperglycemia. See, we should avoid hypoglycemia. That is the first important pharmacotherapy. Most important thing is. Another thing is, what are the drugs which are usually can be given? Number one, metformin can be given. Metformin mainly inhibits the hepatic glucose production by inhibiting the gluconeogenesis in liver and improves glucose uptake by the muscles. So metformin remains the first choice of glucose-lowering drug in the elderly. Metformin is contraindicated in the presence of renal failure, GFR less than 30, and unstable angina, cardiac failure. Low cost and lesser hypoglycemia make metformin simple first choice. And there are other benefits also with metformin. The concerns are anorexia, nausea, vomiting, diarrhea, and constipation. If the patient has a lot of GI problems, then we may have to avoid this or reduce the dosage. And main warning is if there are hepatic disease or if the patient is having congestive heart failure or advanced renal insufficiency, we cannot give this. Next, sulfonylurea should be avoided with caution. They should be used with caution. And only gliclazide MR and glimepiride instead of glibenclamide. Glibenclamide should be avoided in old people. And they are associated with reduced frequency. So gliclazide MR can be used. Start with small doses and increase it. Then alpha glucosidase inhibitors are specifically target the postprandial hyperglycemia and have a low hypoglycemia risk. So making theoretically attractive. This is also, we can give the Voglu and Carbos and other things we can give. Then thiazolidinones have associated with the risk of weight gain, edema, heart failure. We cannot give pioglitazone and other drugs in this. Carefully we have to give. In a healthy elderly, without any cardiac problems, we can use, but otherwise we should avoid this medicine. DPP-4 inhibitors are useful for postprandial hyperglycemia, impart little risk of hypoglycemia and are well tolerated. DPP-4 are also good for elderly diabetics. GLP-1 agonists are also target postprandial hyperglycemia and impart low risk of hypoglycemia, but their associated nausea and weight loss may be problematic in frail elderly. For old frail elderly, we cannot use this. SGLT2 may be used in otherwise healthy persons with adequate nutrition and hydration while keeping vigilance on complications like asthmatic dialysis, hypotension, and other things are the main complications in elderly people. So we have to be careful in such patients. GLP-1 RA may be used provided injectable therapy is accepted and tolerated. DPP-4 inhibitors are good, low risk of hypoglycemia, easy dose regimen, excellent tolerability profiles, reduction in HbA1c with a higher baseline. So they can be used, number one. SGLT2 also can be used. They have extra benefits of weight loss, improved blood pressure, and lipid parameters. Also, and now in cardiac cases also, without diabetes also, people are using SGLT2 inhibitors. Next, SGLT2 inhibitor concerns are urinary tract infection, genital mycotic infections, hypotension or volume depletion, hypoglycemia, renal insufficiency. So risks and benefits of SGLT2 inhibitor should be assessed in older patients. Properly assess and give them. Another thing, insulin therapy in elderly. First thing is that we do that watch test, clock test, and if the patient is able to take insulin properly, then we can hand insulin if it is required. The indications of insulin are similar in adults of all age groups. Long-acting basal analogs are associated with lower frequency of hypoglycemia than intermediate-acting and premium. So one glargine or one injection can be given. If basal insulin is required, prefer preparations with lower risk of hypoglycemia and nocturnal hypoglycemia such as degludec or U300 glargine. Yes, this can be used. Degludec also if patient afford. If prandial coverage is necessary, prefer pre-mixed insulin analogs or co-formulations with a lower risk of hypoglycemia and nocturnal hypoglycemia. Biphasic aspart or biphasic lispro, insulin, degludec, aspart can be used. So low mixture should be preferred over high mixtures. I didn't understand. Once daily regimen should be preferred or twice daily. Yes, as far as possible, patient should be given such a regimen that, okay, once if he takes a long-acting insulin in the night or in the morning, that should be covered. Pen devices should be used instead of the syringes because they will not be able to see properly, take the correct dosage and all these things. So nowadays in the pens also the numbers are visible so well that they should be using only pens. Another important thing is they should be all the elderly or their uh, supporting staff or their family people should be advised regarding these things. Foot care of the people. Number one, wash your feet, dry your feet, especially between the toes. Keep the skin soft with the moisturizer, but don't put the moisturizer in between the fingers. Inspect your feet every day with a mirror. It's better to see the mirror because in diabetics, the sensation is so less sometimes that even if there is an injury, the patient doesn't feel at all. Ask your diabetes care team how to take care of the toenails and the trimming and other things. Wear clean, soft socks. Keep your feet warm. Never walk barefoot. Examine your shoes every day. Well-fitting shoes also should be there. Debulking shoes, when a diabetic foot fellow comes, we have to prescribe the special shoes for him. And another thing, part of this treatment is immunizations. Elderly adults with diabetes should receive vaccinations according to recommendations. At least pneumococcal vaccine after 65, once in 5 years, and a flu shot once in a year we should give, and other things also. Next, screening. This is important. Elderly with diabetics should be encouraged to undergo recommended age and sex-appropriate cancer screening and also reduce their modifiable cancer risk factors like obesity, physical inactivity, smoking, and other things. Because diabetic elderly themselves are prone for this cancer and other things, and diabetics are still more prone. Effective behavioral management is very important, and psychological well-being are foundational in achieving treatment goals for people with diabetes. It is essential to achieving these goals. What are the essential things? Diabetes self-management, medical nutrition therapy, routine physical activity, smoking cessation counseling, psychosocial care. All these things go in this treatment of diabetes. So the guidelines and summary are: the elderly represent distinct yet heterogeneous group of persons with diabetes with their unique physiology, pathophysiology, clinical features, needs and challenges suggest that they need an individual. Each patient is separate. We have to take history. It means we doctors don't have time to take such a detail. We must be assisted with other paramedics who take a good experienced nurse can do all these things. They can take the history properly and come with to us, and then we can prescribe the medication. The elderly aim for relaxed targets and avoid hypoglycemia. Tools and interventions used should be safe, well tolerated, easy to administer while requiring minimal monitoring. Personalized strategies are needed to avoid over-treatment of the frail elderly. In older person with diabetes, multiple comorbidities or frailties, strategies should be used to strictly prevent hypoglycemia, which include choice of anti-hyperglycemic therapy and less stringent A1C target. Fit elderly, same thing, 10 years overlap, HbA1c target should be like any other younger adults. Frail elderly, it should be higher. Pharmacological treatment options are similar to younger options, and avoidance of hypoglycemia is important. Evaluation and treatment of micro and macrovascular complication diabetes in elderly must also be individualized. And diabetes management in older adults requires careful assessment of clinical, functional, psychological factors. The take-home message is target for glycemic control should be individualized depending on the life expectancy, functional status, and comorbidities. Other genetic problems should be taken into account while managing diabetes. Comprehensive genetic assessment has to be done before starting pharmacological therapy. Team approach to management is essential. Risk factors like isolated systolic hypertension, hyperlipidemia management may benefit elderly diabetic morbidity. Tight glycemic control may not be beneficial in several cases. Elderly patients should be treated with the principle of start slow and go slow. Thank you very much.